Hello and welcome to this slightly ambitiously titled event after the pandemic, long-term health and social care funding challenges. Apologies for the slight delay in the kickoff, but welcome both to those in the room and those joining virtually. My name is Graham Atkins, I'm an Associate Director at the Institute for Government. Thank you very much for joining us for this event, which has been supported by the Health Foundation. So, over the past 18 months, the pandemic has hit health and care services hard. The NHS has had to redeploy the vast majority of staff twice during the first and third waves of COVID, both to staff intensive care wards and to respond to COVID. The NHS still is operating with enhanced infection control procedures, which has reduced the amount of care it can offer. And as of July this year, and probably a figure that I imagine many of you are familiar with at this point, there were 5.6 million people waiting for an elective operation. That's almost 30% more than the kind of pre-pandemic equivalent in July 2019. But even before that, the NHS had a large number of vacancies, was increasingly undertaking large numbers of operations, and had routinely been missing all kinds of waiting times targets by increasingly large margins. So what can be done? How much money would it take to catch up with waiting lists? Do we need a more resilient NHS? And how on earth might any of this be paid for? So to discuss these issues and more, I'm really delighted to be joined by a great panel. We've got a wealth of expertise, both health and economics and elsewhere. We've got Anita Charlesworth, Director of Research of the Real Centre at the Health Foundation, Gemma Tetlow, Chief Economist at the IFG, Sarah Neville, Global Health Editor at the Financial Times, and fourth, we hope to be shortly joined by Paul Bristow, a member of the Health and Social Care Select Committee. So after opening remarks, I'm going to ask a few questions to the panel before opening up to a Q&A, and then aim to close this event at quarter to 5. Before we kick off, I just want to make 3 brief housekeeping arrangements. We're not sitting in a particularly brilliantly ventilated room, so if you do have a mask with you, please wear one if you have one to hand. We will be live tweeting from @IFG events using a hashtag IFGcons21, so please do follow and tweet along. And this is a public event on the record, so there will be an audio and video recording uploaded online afterwards. So with that in mind, I'd like to kick off with you, Anita. The government set out big plans to build back better in health and social care. It's promised it's going to tackle growing waiting times and reform social care. So with all this new money going in, what is the outlook? What can we expect from health and social care funding over the next few years?
Yes. So I'll first of all talk through the nature and of the pressures on the NHS, broadly speaking, over the decade, and then on social care. For the NHS, there are 3 very obvious things that we're going to need to address over the rest of this decade, and one very significant choice. So if I start then with the things that we're going to need to address, one of the absolute critical things, which at the moment is obviously an enormous uncertainty, is just what does COVID look like over the medium term. So we're moving from a pandemic phase of the virus to endemic disease. But what does that endemic disease quite look like in terms of scale and nature of outbreaks? How long are we going to be vaccinating people? How many people are we likely to have in hospital, kind of adding to winter pressures? Are they winter, or does it manifest in a slightly different way? And if COVID continues to circulate in the population as a significant issue, what sort of infection control standards do we need in hospital? And the latter point sounds really techie, but is actually really decisive in this, because the need for social distancing and infection control means that for any given number of doctors and nurses, number of hospital beds, we can see very many fewer patients, because everything takes that bit longer, and it's that bit more complex. So that's been actually one of the biggest effects, if you like, of COVID. It's that it's not so much, other than obviously at the very peak, the cost of the patients who were in the hospital directly with COVID. It's that to manage that risk in hospitals requires them to operate in a very different way. And that adds enormously to cost. And brings me to the second issue then, obviously, which is the backlog. So we're all very aware, I think, that there are 5.6 million people on the waiting list. That means probably we all know somebody who's waiting for care. But the expectation is that actually that is not the highest that the waiting list will go. So during COVID, obviously many people have not been able to, who were already on the list, have not been able to get treatment as quickly. But a lot of people who would have expected to have come through to the waiting list have not appeared so far. And the estimates are that there's up to 8 million people missing from the waiting list. And what no one's quite sure about is how many of them come back. And this is, when you add that in, that's where you get to the sort of figures that Sadi Javid has talked about, of a waiting list potentially of 13 million people. So the really toxic combination is 13 million people plus ongoing infection control, really constraining the way that hospitals could operate, and repeated outbreaks that mean that things like intensive care is under pressure, and we can't do surgery, planned surgery all year round. Those are the third thing, though, is that the NHS, for those of you who are Lewis Carroll fans, I always like to describe it as like the Red Queen. By and large in the NHS, you have to run to stand still. So there are more of us in this country. We are getting older. We seem to be having more chronic disease. And also, very wonderfully, it's a problem of success, we can do more. So to maintain standards, we're having actually to provide more care, and that costs. So those three things together, if you take sort of, reasonably optimistic assumptions about COVID, assume 75% of that, those missing patients reappear, some fairly modest assumptions about underlying pressures, you're into a scenario where the NHS is going to need funding growth that exceeds inflation, exceeds economic growth for the rest of the decade, rather than the sort of 3 years that has been so far we've identified as receiving the levy money for. And then the big choice, I think, for government, which will come out, I think, as quite a theme in the COVID inquiry, is how far we prioritise resilience. And in addition to meeting those direct service challenges, we try to build a health service which has, if you like, a bigger buffer for unexpected events, because scientists think that whilst hopefully something on the scale of COVID is unlikely to happen very quickly again, it is nevertheless the case that they're expecting more of this kind of infections to appear. And we went into COVID with fewer doctors, nurses and beds and scanners than most of our European partners and North American countries, which meant that we had very little capacity to deal with this. And obviously, if we wanted to have more resilience, that means you're not running your system as hot on the peak of efficiency. And this is an issue, obviously, across the economy with things like just-in-time supply lines, the issues we've got at the moment, with the concerns around gas. Have we prioritised operational efficiency over resilience, and where as a country do we want to be on that? So obviously the plan was that in some senses that the NHS had the backlog. That was 3 years. It would get 3 years of the bulk of the levy money, but then the backlog would be worked through, and then social care would receive more of the levy to do obviously the cap. But the cap is one really, really, really important issue in social care, and I think it's a missing pillar of welfare state. But it's not the only issue. And again, just as I talked about underlying pressures in the NHS, we've got underlying demographic changes affecting social care. We're all obviously aware of the ageing of the population, but again, problems of success. Very wonderfully, actually, we have more younger people with learning disabilities, with other forms of disability, who are living much longer than they used to, but needing a lot of care. So Down syndrome life expectancy is now almost 60, whereas, I mean, certainly when I was a teenager, it would have been under 30. Yeah. So those issues, equally in children's services, issues, expectations are also rising. If you take children with autism coming into adulthood, their parents, their families, they themselves want to do a lot more than just live. Yeah, but that needs help. You've also got an issue of provider sustainability, and critically within that, the workforce for social care. And then finally, access to care, because many people, older people, have unmet needs and are not getting help and support they need. So very big agenda on both social care and NHS. Big question about whether or not the levy can do it all and where the funding comes from after 2025.
Great, thanks Anita. That's two very clear big challenges and a question. Suddenly that extra money isn't sounding quite so massive. But Gemma, can I come to you and perhaps to extend Anita's Lewis Carroll metaphor, to the rest of the public sector? The NHS often looks like Alice in Wonderland with the scale of the funding increases it gets. So really, what's the wider picture? What can we expect over the course of the next few months of the rest of public services?
Sure. I mean, if you look at the numbers that the Chancellor has set out as being what's the pot of money that's going to be available to allocate in the spending review, once you strip out the money that's already been allocated to the NHS, to social care, to schools, to defence, to overseas aid, that does leave quite a tight settlement for the other unprotected areas of spending. It's not as tight as the last two multi-year spending reviews we've seen in 2010 and 2015. In 2010, we had a real terms cut for those unprotected areas over the whole course of the spending review. In 2015, a small real terms increase. This time, slightly more money available, but the profile of that may be quite difficult to deliver. So as it stands, the planned increases for those other unprotected areas is pretty much, it's actually a small real terms cut in year one, a small increase in year two, and then most of the money is coming in year three. And that will be pretty challenging to deliver, given that it's not just the NHS and social care that are coming out of the pandemic with some pent-up needs. There's obviously demands to try and catch up on the lost schooling that kids have had. Some money has gone into that, but not as much as Kevin Collins had asked for. There are quite significant backlogs in the courts, for example. There are also some existing sort of pressures in other service areas. So the government has committed to recruiting 20,000 extra police officers, for example, but no extra money has yet gone into the courts and prisons system to sort of deal with the knock-on effects of having more police officers who will presumably be arresting more people, sending more people to court and putting more people in prison. Right across the public sector, there were issues growing before the pandemic around recruitment and retention of workers. So that's certainly an issue in the NHS, which Anita's already talked about, but it was true across other public services as well. And partly that stems from the fact that post-financial crisis, one of the ways in which public spending growth was held down was by imposing freezes and then small real terms increases on public sector pay. There was a certain amount of mileage in that policy, but even pre-pandemic, it was getting to the point where lots of public services, whether it was teachers, police officers, prison officers, were struggling to recruit the numbers that were needed and to retain experienced staff within those services. So one real question for the services they face another round of tight spending growth will be, how do you do that if you don't really have much further to go in terms of holding down pay growth, which is a big part of the budget for a lot of these services. And there are obviously new aspirations from the government that it will want to deliver on in the spending review, in particular the aspirations around levelling up. So I think the spending review will be interesting to see what the government sets out as its priorities. Are those the same priorities it had pre-pandemic, or has the pandemic changed how it thinks it now wants to prioritise that spending? There will be more money available in the spending review for capital spending. That budget is a bit looser. The government wants to spend up to 3% of GDP there. So there may be more mileage in extra money for infrastructure than there is for extra money for day-to-day service delivery. To end on a sort of more positive note, one of the things that the pandemic did do was to give a real kick to innovating ways of delivering services. There was a lot more use of technology right across the public sector, whether that was greater use of digitised transfer of information between police forces and the courts, whether that was seeing your GP virtually. Obviously, kids were taught virtually. And so one thing that hopefully the spending review will grapple with is understanding which of those things actually really worked and improved the delivery of services, made things more efficient, and should be continued with and embedded within the way services are delivered, and which of those actually were necessary during the pandemic but really aren't right to continue with. I mean, I don't think anyone thinks we should continue to teach our kids virtually. They're going back to the classroom. So there'll be a mix of those practices that have worked, and this was a really good kick to get people to try things, to do things differently, and those that haven't so much.
Thanks, Gemma. So not an entirely rosy picture, but some reasons for optimism. So Sarah, if I could put a very practical question to you. I mean, there's loads of staff vacancies. There's still quite a lot of bed shortages. We're still caring for some people with COVID in hospitals. I mean, like, what levers can the government actually pull to tackle some of these problems?
Well, there's no question that the government is facing some truly wicked challenges here. Record waiting lists, which the other panellists have referred to, which are in part the legacy of 30 years in which we reduced bed numbers without a corresponding investment in community care. We've got a terribly fragmented social care system for which, as became all too apparent during the pandemic, neither the government nor the NHS has ever really taken responsibility. So there was nobody to fight the sector's corner when it came to getting supplies of PPE or getting their fair share of testing. But nevertheless, I think there is still hope, and I think it lies in what Gemma refers to, the power of innovation, some of which was already happening, some of which has been unleashed by the pandemic. And if we can only disseminate some of this more widely through the NHS, I think it will make an enormous difference, because the NHS is not, to be frank, always terribly good at taking from one part of the system innovations that have proved effective. There does tend to be a bit of not invented here about the NHS, I think. It was interesting actually to see that mentioned with the appointment of General Sir Gordon Messenger to review NHS leadership. That's obviously partly what he's going to be looking at. But thinking about some of the things that I see as a reporter, going out in normal pre-pandemic times, at least around the country, just a mile or two away from where we're sitting now is Salford Royal Hospital, one of the most respected trusts in the country. I think everybody would acknowledge exceptionally well led, and its staff receive their annual pay increments only if they can satisfy their bosses that they're meeting various sort of key requirements, such as undertaking particular training modules. So this is really at least a step towards an element of performance-related pay. And politicians have always been very nervous of advocating that. I think they see it as a sort of third rail for a taxpayer-funded centralised system. But the staff that I spoke to at Salford, and actually their union representatives as well, were very happy with it. And certainly the quality of care that was being achieved at the hospital was exceptional. And one of the other things they did was at the sort of front of every ward, there was a huge whiteboard of information, and it showed things like, when a patient last fell, or the proportion suffering from pressure ulcers. And data was being very clearly used both to sort of reassure families and drive up performance. And talking to the then chief executive, Sir David Dalton, who's actually since moved on, but he really said to me, safer care is also cheaper care, because if somebody doesn't get a pressure sore, they're going to stay in that bed a shorter time. You can save it for another patient. And I guess the real prize for any health system is reducing length of hospital stay. That's the single biggest cost. And again, there are some fascinating examples of ingenuity that I've come across around the country. In Yeovil Hospital in Somerset, for example, one of the nurses had the idea of setting up an ambulatory care unit so that when people were brought in, they didn't automatically get funneled into A&E and thus flow into the main hospital where they would often have been admitted. They were treated and sent home. And, this was a sort of relatively simple structural change in the way patients were, sort of moving through the hospital. It required obviously some investment, but not massive investment, but it's made an enormous difference and has really reduced the length of stay. This admittedly was pre-pandemic. I would have to check back in and see what it is now, but certainly before the pandemic, they'd reduced their length of stay from 5.7 days on average to less than 4 days. And the financial implications of that relatively small sounding reduction are actually enormous. I think the other thing, that Anita referred to was the need to make us as a nation more resilient. And this, of course, means putting a far greater focus on preventative healthcare to reduce all the harms of obesity and alcohol overuse and the like. And here too, we're starting to see some really imaginative and innovative thinking, with an increasing recognition that the NHS actually can't do all this on its own. It may need commercial partners. And we saw a huge deal that was struck just a month or so ago between Novartis, the Swiss pharma company, and the NHS, under which inclisiran, Novartis's new twice-yearly injection to reduce cholesterol, is ultimately going to be rolled out to about 1.8 million people who've been identified as being most at risk of cardiovascular disease. This deal worked for both sides. Novartis got access to a guaranteed volume market, the dream for all pharma companies, and the NHS got a treatment at a reasonable price, which may hugely reduce the number needing expensive treatment for a heart attack in the years and possibly even decades to come. I was going to talk a bit more about technology, but Gemma's already done that. So perhaps I'll leave it there. But in short, I think we can, if we embrace some of these changes, actually see a step up in productivity over the coming years, even as populations continue to grow and age and putting such a massive strain on the NHS.
Great, thanks, Sarah. That's a really interesting note of optimism. It's also just really interesting to hear about what's happening across the country from Salford to Somerset. So, Paul, given some of those challenges and some of the opportunities that Sarah outlined, what should the government be prioritising to build back better?
Well, thank you very much for inviting me to come and talk, and apologies for being slightly late, but I'm so pleased I did come and listen to you, Sarah, because I think what you've said about Salford is just completely up my street and is basically what I was going to talk about a little bit about. So I think that's an amazing to hear that this sort of thing is happening, because every sort of 20 years or so that I've been involved in healthcare politics, health and social care politics, we've been told, perhaps every 2 or 3 years, that both social care and the NHS needs more money, it needs more capacity, i.e. workforce, as well as elective capacity, and a plan. And the key for this government, I believe, in kind of building back better, is that in 3 years' time, that we don't have the same call for more money, more capacity, and a plan, and that we're actually doing this. The question was, what things do we need to do that demonstrate levelling up? I mean, I think first and foremost, the biggest challenge that we face is obviously managing the elective backlog. I feel very sorry for a lot of NHS staff, because we've been told that this is an enormous national emergency, COVID, and they've got us through this amazing, challenging kind of process. But just as we get through the process, just as you get over the top of the mountain, there's an even bigger mountain ahead of you, which is now the managing this sort of backlog. And for me, I think this again is a national effort worthy of central government passion and delivery, because and we've also obviously got the money, but in order to try and get through this backlog, it's not as easy as just throwing money at it. There's a number of different challenges here, and I'd just like to go slightly through them. The first is around workforce. I think that was been talked a little bit earlier. You can't just grow consultants on trees. They take 7-8 years to come through, and we need to obviously start talking about how we train these consultants, train our healthcare professionals, and we do that now. We need to double, quite frankly, the number of people who are training in this country, and we need to make sure that we are delivering this in 7 years' time. But we don't have 7 years to deal with this crisis, and so obviously we need to use overseas. I'm afraid that's just going to happen, but there's a global shortage of healthcare professionals. We're going to have to compete with everybody else to do this, but it's going to in part come from overseas. But it's also going to come in part from retention. And we need to think about how we actually ensure that our healthcare professionals don't retire or don't go part-time, and that we're using them as kind of productively as possible. And a lot of that actually revolves around how we use more other healthcare professionals to free up GP and consultant time, because quite frankly, we're just not doing that at the sort of scale that we need to. And the reason is certain legislative things we can do around extending prescribing, but why are GPs still prescribing the pill? We really need to be ensuring and freeing up that clinician time to get them doing what they should be doing, which is treating the sick. We need to be ensuring that surgeons are not spending one day a week in the in theatre. They need to be spending far more time doing that. Some other issues around capacity. One thing I do worry about, because I whether it's true or not, I heard several stories about some sort of ideological reluctance from some in the NHS to use independent capacity that we've quite frankly the government have had to purchase in to use. That we can't have the luxury of that anymore. We've got to kind of get away from the politics of that. We need to power through these elective backlog. We need to the surgical hubs and the diagnostic hubs. Well, surgical hubs have been talked about. Diagnostic hubs, I think we also need as well. And we also need to think about tariff, I think, as well, because at the moment we're talking about changing tariff, which is payment by results, and health bill going through Parliament. For me, we need to ensure that we have a tariff system that allows us to power through hernia, power through cataract, power through hip and knees, which are going to be a significant proportion of the backlogs, these big volume elective procedures. I could talk to you quite a long time about how we reform tariff, but I don't want to bore everybody. But then, so that's that kind of one issue. The other issue, obviously, is social care, and just briefly, I'll just talk a little bit about that. I mean, I think we need to spend these 3 years, until the money apparently is coming in to help solve our social care crisis, coming up with a plan that will solve our social care crisis, and it can't be just sticking plasters over the current challenges that we've got. I think we need to when we talk about aligning social care and NHS and integrating them both, but we need to bring other things into it. Housing, for example. I mean, I think we need people out of residential and nursing care, expensive settings, for as long as we possibly can. We need to keep people in their own homes. We need to ensure that they're treated properly. If social care is the Cinderella service compared to our NHS, well, the domiciliary home care is the ugly sisters. It really is kind of ignored, where it's a significant proportion of our social care proportion. We just really need to ensure that we devise a system that incentivises people to be kept in their own homes and people treated in that setting, and whether that's some sort of commissioning based on outcomes or some other system, I think that definitely needs exploring. And just kind of finally, the third thing is on public health, and we've touched on that slightly a little way about what does levelling up mean. Well, we've got a huge obesity crisis in this country. The pandemic proved that without a doubt, because many more of us died of COVID, probably because we were overweight more, than anything else, and that's a challenge. Diabetes is now consuming a frightening proportion of our NHS budget. We need to solve that problem for the future, and I think that's what levelling up looks like as well, in terms that we don't have lots of people in my constituency and other parts of the country that are not as wealthy as they might be, developing diabetes and having their limbs removed, and all sorts of kind of problems associated with that. Technology and self-care is a huge part of this. I'm fed up of people telling me that older people or people on low incomes can't use technology. They do all the time, and we need to kind of do that. And self-care and managing the conditions on technology is part of that. I could talk for a little bit longer. I'll kind of leave it with that. But on a sense of optimism and hope and all the rest of it, because some of the other kind of colleagues did this. I think just two things. I think innovation has got the way to kind of get us out of this. The NHS has proved it can innovate. We had 3 years worth of innovation in 3 months as a result of COVID. We've got to keep pushing that and make sure that the foot doesn't come off the gas. And if this is a national effort, that we need positivity and optimism, and we need our NHS staff and all the rest as part of this team to feel valued, supportive, and feel they're part of a national effort. I don't know another politician better suited to that, quite frankly, than Boris Johnson, because whatever you think of him, and I'm obviously a huge fan and supporter, but Boris is universally positive and optimistic, And I think that's the sort of person we need in this time of crisis.
Thanks, Paul. Really interesting, wide-ranging set of comments. And I'm going to put a couple of questions to the panel before opening up for Q&A. So I was really struck by one thing you said about, the success of this is if in 3 years' time we don't have the same discussion. One really notable thing is that health and social care levy is for 3 years. So Anita, what do we need to do to not have this discussion in 2024?
Well, in part, I think what we need to do is recognise that we are going to be continually talking about NHS and social care funding and capacity, because it's a huge part of what the state does, and it's and the medical advance, the changes of our population mean that we continue to need to decide what scale of services that we want. And that's public funding. We're a democracy, so we need to talk about it. I think what we want to do, though, is to be in a position where the conversation is different, in that it's not a conversation born out of crisis.
Yes.
Yeah, that it is a conversation, and where we're very clear to the public, they can see that if the spending has delivered real value, and actually the bigger these areas of public services become, the more important it is, I think, that we're able to demonstrate value for money. But both because it's so much spending, it has implications elsewhere. But also, actually, I don't think you can continue to make the argument to the public unless they're very clear that you're spending every pound very, very, very wisely. But I think it's eroding confidence to think that this won't be the core of politics for the future, but hopefully it's about the politics of success rather than the politics of crisis.
Yeah, I'd take that.
Thanks, Anita. I think that's a really interesting point. So if the challenge is demonstrating value for money, obviously a lot of that is really about data. I mean, in Gemma, what do you think the government needs to be looking at or collecting data on in order to actually show that this spending is delivering something?
There's lots of the NHS where there is fantastic data. We had amazing real-time information on how many people were in hospital with COVID, how many beds were occupied. All of that sort of data on the sort of acute end of healthcare is fantastic. We have much, much worse data on what's going on with community healthcare. We have very poor data on social care, in part because it's fragmented across with lots of different private providers. And I think that did show through in the pandemic that you had a real focus on the problems in hospitals. It was much harder to get a handle on and really kind of get the public to understand what the issues were with what was going on with social care and with domiciliary care, which Paul talked about. So I suppose my one call would be, let's get good quality data on community care, on social care, to really understand what are the problems, what are the gaps, where have those services been scaled back, and where do we need to do more. And I think that might help to perhaps slightly overcome the tendency that political focus always goes on to the urgent over perhaps the important. If we had a bit more sense of some of that important but not quite so headline grabbing work, that might help.
That's a good point. And I think, Paul, I'd be really interested in your views on this. I know you're interested in data in general. I mean, what more do we need to gather so we're looking at a national health service and not a national hospital service?
Well, on data, I mean, I think I'm a huge supporter of better use of data, because I think that's how you kind of track performance. And I think what we really need the problem as I see it is, and the health bill may come some way to solving this problem, is that there was a huge tendency some time ago to seem to be quite fashionable to try and let's take the politics out of the NHS, let's make them independent and all the rest of it. But as Anita quite rightly said, you're never going to take politics out of the NHS because it's a huge political issue. It's a huge element of what the state does. And when you have a problem with operations or something, people write to their MP. They don't write to Sir Simon Stevens or anyone else in NHS England. They obviously write to me, in Peterborough. So I think an element of political kind of involvement in politics in our NHS is good, and it comes down to this data point, because if you are going to hold NHS chief executives who are paid, or trust chief executives are paid huge amounts of money to account for performance and general KPIs, then you need the data to kind of prove that, and it helps for better decision making. We also need to throw open the windows and have an element of transparency in our NHS and figure out how they make decisions. You don't have a situation where for hip and knee replacements, they rationalise hip and knee replacements for those who have a BMI of over 30, or in some alarmingly cases of over 25. That's me out. But these kind of decisions can't actually be taken and concealed on page 243 of a 400-page document hidden online somewhere. We need far more kind of transparency over decision making in our NHS in order to get value for money. And ultimately, the only way we're going to manage this elective backlog is if the NHS does become more productive and we get value for money.
Thanks, Paul. So I just want to talk about one kind of wider theme before we go to an audience Q&A. We talked a lot about immediate pressures and the backlog and staffing. But over the longer term, I was really struck by Anita's point about resilience. Has the pandemic illustrated the need for a more resilient health service? Sarah, you wrote a really interesting piece for the FT the other day about what other countries outside the UK are doing. Is there a case for a more resilient health service after this?
I think there's absolutely no question that health has to be at the heart of levelling up. And there's, I think, one way in which the NHS can actually play a crucial role, which hasn't been mentioned so much in the levelling up documentation, but it's this phrase that one started to hear about the NHS being an anchor institution. In other words, an institution that not just provides healthcare in a community, but also provides high quality jobs, that has a commitment to procure from local businesses. So it can actually play a role in driving up the economic health of the community, and health and wealth are obviously very inextricably mixed. So I think that's something that we do all need to think about, alongside the more obvious ways in which we need, as other panelists have mentioned, to act on preventive public health. As we all know, has been shamefully unfunded over the last decade or so. It hasn't remotely kept pace with the uplift to the NHS England revenue budget, and Public Health England came under enormous attack in the earlier part of the pandemic, but it had faced absolutely eye-watering cuts. I think its budget was cut by 40% over 7 years. So there is an enormous challenge here, but there's also an enormous prize, I think, in terms of making us a more resilient population.
Thanks, Sarah. So Anita, public health, shamelessly underfunded. Do you agree? And what should priorities for resilience be?
Well, certainly the economic evidence, if we're trying to look at how to achieve health outcomes cost effectively, is that £1 spent in prevention, and typically the sort of services that Public Health England and local authorities deliver, is 4 times more productive than £1 spent on the treatment end. And it's been the goal in the UK, and as it is actually in many other countries, to shift the focus of the NHS from, as someone said, a sickness service to genuinely a health service. So there's one where taxpayer, health service and individual interests are all aligned. We'd all like to live healthier for longer. So looking at the balance of spending between day-to-day running costs and public health is right. It's also the case, obviously, that if we're thinking about how we build our resilience for future health shocks, services are part of resilience, but actually a population that is healthier is also part of the resilience. And that's money we'll never regret spending. So, if actually we could tackle obesity, reduce smoking, even if there was never another pandemic, Yeah, that spending has not gone to waste. You know, it's not like when we did the flu planning a decade ago and we had Tamiflu stock stuck in a warehouse somewhere, you know, that aren't doing anything until you actually have the crisis. You know, in the case of a healthier population, it's a no regret strategy. But I guess it's worth saying that whilst the NHS and public health services can do a lot, this is also actually about a much wider agenda to improve health, and this is where having a health component to the levelling up agenda is so critical. Thinking about what communities need to become healthier, thinking about the role of business as well, and thinking about the contribution of other public services like transport, like education.
Thanks, Anita. I was really struck by the comment that public health is 4 times as productive as acute health. So it kind of begs the question, Gemma, if all of this money is a brilliant, no regrets idea, why have governments found it so difficult to fund?
I mean, I think that comes back to at least in part, to points we've mentioned before. Public health is not quite as obvious to people, and the underfunding of public health tends to manifest in problems that take quite a long time to develop, and it's not quite so obvious the link between the lack of investment in public health and what the problem is. So the thing you see happening acutely is lots of people ending up in hospital with diabetes, needing amputations, but it's not obvious that might have stemmed from a lack of investment in public health. So I think they're slightly slower burn issues. I think better data could help with that, to understand what is being done on public health. In parts, there may be issues with public health responsibility having been transferred over to local authorities. There are obviously lots of positives from doing that, because these are kind of interventions that really are local area based and have complementarities with other things that local authorities do. But there has been a tendency over the last decade for local authority budgets to be cut much more dramatically than the NHS budget. And so those local authorities have faced choices between spending on public health and social care for both children and adults. So I think those may be some of the issues.
Great. Thanks, Gemma. And so, Paul, public health, healthier population, local government, education, transport. What is the thing this government needs to prioritise to build a more resilient health service?
That's a very tricky question. I mean, I think it just comes down to what I said earlier on. I mean, I think the NHS desperately needs to become more productive and get a bigger bang for its buck. Now, we've just heard that public health is a very cost-effective way of cost-effective intervention. You know, I've got no argument about that. I absolutely agree, and I think public health, especially on obesity, is really now a must. We have had success with smoking cessation. I know perhaps it's stalled relatively recently, but generally smoking, the levels of people smoking has dropped considerably. But I think now obesity and diabetes is the biggest sort of public health challenge we face, and I think we desperately need to prioritise that. But look, the NHS, I mean, I hear what Anita's saying, and I don't disagree with her. We are all living longer. We are going to, the NHS is going to require funding and funding increases in the future. But, it's already, a huge element of public spending. And the public won't forgive a government which puts up its taxes and then fails to get bang for buck in return. And that is the biggest challenge. It's about making sure the NHS is more productive, and that probably involves kind of issues in three areas. And I've kind of said it in previous fringe. And the first is on management, and I'm very pleased. The name slips my mind, but the Army General has been appointed to look at this, and that's something I think is really crucial. We need to. If you look at my local authority, the Chief Executive of Peterborough City Council is also the Chief Executive of Cambridge County Council. The Finance Director is also the Chief Executive of several different councils. And it goes on about the HR Director, Procurement Director, and all the rest of it. The reason that had to happen because local government have not been had generous funding settlements recently, and they had to save money in their management. The NHS, I'm afraid, has got to do the same. It really does. There's no discussion in that now. I think the NHS also needs to deliver considerable savings when it comes to treatment. When I say savings, not necessarily financial savings, to treating more people. You know, we've got organisations like GIRFT, we've got organisations like NICE. We give them money to assess, you know, various different technologies and treatments and pathways and quality standards, and then we don't follow it. Well, certain trusts don't. I mean, what's the point in doing that if we're not going to tackle this, you know, kind of not invented here syndrome? People look at this for a reason, so we need to, you know, get these things in place, and that will, I think, drive productivity. And I also think, I've said it a number of times, if we improve clinician time to be doing the things they need to be doing, treating the sick, in the diagnosing people in the operating theatres. Again, that's what we need to do. They don't need to be spending, you know, kind of acres and acres of their time on bureaucracy, on doing, you know, things they shouldn't be doing. Quite frankly, we need other colleagues in the health service to be doing a lot of their sort of things that consultants don't need to be doing. And I think, again, that will improve productivity. But there are just three things that I've identified. There are lots of other things we can do to try and ensure that we get bang for our buck in our health service.
Great, thanks, Paul. So I'm now going to start asking questions from the audience. We're going to take questions in clusters of 3 to get through as many as possible. Okay, you've all already raised your hand. You don't need to be told that. That's good. Please keep your questions short and to the point so we can get through as many as possible. Can we go through the lady in the green dress, the gent in the front, and the lady on the left-hand side?
Hi, Susie Martin, Altrincham and South West Conservatives. I'm also a nurse as well. My question is about recruitment of nurses. At the moment, the main way of nurse training is by doing the university degree, and then when they qualify, a lot of nurses, because they've got such limited experience, they're supernumerary for a year. So effectively, they're being paid for a year and they're not actually hands-on. And my question is about going back to the old style of a degree, degree apprenticeship. You know, when I trained many, many moons ago, we were hands-on from day one. We could do everything but take control of the ward, and then when we qualified, we were up and running. And I just wonder why that can't be more implemented now. It would kill so many birds with one stone. You know, the students wouldn't have the debt, etc., and you'd have a workforce for that 4 years of training.
Great, thank you very much. Yep. Sorry, woman in the middle, Penny, and then the gent in the front.
Hi, Emma Mee. I'm a GP trainee in Oxford, and so in primary care, one of the main challenges, which I'm sure everyone is familiar with, is that, you know, very short appointments. GPs find it really difficult to deal with that. But then you also look and you see that, you know, for people have, like, you know, they see their GP a few times, they see somebody else, so they end up seeing about maybe 3-4 times for the same problem, and so it strikes me that I think we need to try and move towards more of a single assessment model to release capacity, and then people get better quality care as well. And this is a part of a broader spectrum, I think, of it's about the way that people work and the way that you practice and the way that people view the professions and the specialties work together, which is basically the clinician's remit. And like GPs also, I think, their skills are underutilized. If you, with the appropriate training and maybe some sub-specialization for some GPs, you could manage the dermatology, the community gynae. So what do you think about that, and how do you think we affect change in that?
Great, thank you.
Hello, Tony Johnson, Cheadle. I just wanted to ask about governance, because I think that's vital, and the accountability. Greater Manchester had health and social care devolved to it more than 6 years ago, yet we've had no reporting on the 6.5 billion that we started off spending, and I think there should be accountability to local people so that we can see where the money is going and where it's wasted. I mean, normally when organisations come together, you look for quick wins, but there's been nothing.
Great, thank you.
Can we hold Andy Burnham to account?
Thank you. So 3 really interesting questions. One about nursing degree apprenticeships, one about moving towards single assessments, and one about governance and local accountability. Paul, on the governance and local accountability question, what do you think?
Well, I mean, I completely agree with the gentleman. It's similar to what I said, really, in my remarks. I think we really do need to have political and accountability on performance. You know, like, as I said to you earlier, I think whether it's NHS England and specialised commissioning, or whether it's localised commissioning, I sometimes feel frustrated that there is no way to influence the criteria in which that's being applied. My CCG, it's slightly different because it's a different thing, but my CCG has only just reinstated fertility treatment. It's one of the only sort of areas of the country that didn't offer fertility treatment on the NHS. Now, whether you feel they should or shouldn't, this was looked at by NICE and said that they should, and they've totally just ignored it because of short-term funding pressures. And when I kind of challenged this as an MP on behalf of my constituents, I was told it wasn't any of my business. But, ultimately we ended up with, all the MPs working together, and we ended up getting it re-established. But the point of our story is this, is that I think a lot of the time, decisions are being made on commissioning, decisions are being made on criteria, on rationing and all sorts of different things with no real accountability. We need to throw open the doors, again the windows, bring the fresh air in, bring that scrutiny in, and that's how you improve performance, because without data and transparency, there's no real driver there to improve performance. So I completely agree with the gentleman.
To let the sunshine in. Anita, what about nursing degree recruitment? Is that a solution to the workforce problems?
So I do think apprenticeships are really important route into nursing, and there is now the degree level apprenticeship. I think it should be a goal to expand it more, and I think that for three reasons. I think one, it's important for numbers, but secondly, I think there are some of the areas of nursing that are struggling most. If you take learning disabilities, mental health, community, areas that often took people from other walks of life first, with different range of rich lived experience, which it's really valuable. They don't necessarily want or can able to just go off to university and study that way. You don't reduce the standard by doing a degree level apprenticeship. You keep the standard exactly as high, but you get all that richness of lived experience. The third thing is the point that Sarah made about this horrible bit of jargon, anchor institutions. So we've got lots of parts of the country where we've got people who need good jobs, yeah? And we've got lots of parts of the country where the NHS struggles to staff. Coastal areas, more remote areas, very common here. And we know from lots of the work around the world that if you can train people locally, they stay and they're very loyal. Whereas trying to parachute people in and persuade people to move to those areas is often very hard. And then you've got a workforce that reflects the community it serves, understands a lot of that local context and a lot of those issues, and you're actually bringing wealth and economic opportunity to people in those communities. So I was thinking holistically around this and really growing the apprenticeship. And I don't understand why, but there are lots of problems at the moment where the NHS is saying it's actually much more expensive for them to train someone as an apprentice than it is to take an undergraduate. And that just seems one of those things where government has got to fix that, because that is in nobody's interest.
Great, thanks Anita. That sounds like it might be a rare case of a win-win in policy. So primary care, single assessments, to some extent rationalising the number of people that people see. Does anyone on the panel want to come in on a primary care question?
I don't mind coming in a bit, because I think it's a really important point as well about the inefficiency issue, in that a lot of the time when people talk about inefficiency and when they've had care, the real things they see are the being passed from one bit of service to another, seeing someone, that person couldn't give them the answer that they needed, they couldn't actually do something because something else hadn't been ordered. And this is where often we talk about inefficiency and productivity, and it sounds very off-putting for both the public and professionals, but actually it's the bugbear of most patients and most professionals working lives. And it is where we actually need to make sure then, and one of the opportunities I guess in the bill with is some of the new infrastructure around integrated care systems, is to look at all the different care that's provided and how we use all of that optimally, and making sure that we do that will be absolutely critical. So to the point about retention, because a lot of this is a huge frustration in people's jobs, and in the end they kind of, I've just had enough, I can't do this anymore.
Great, thanks.
Could I just say, I think there's also something here about incentives, that hospitals are still largely paid on activity, so there isn't the incentive for them to see people treated at an earlier level. Because if I understood the questioner correctly, you were talking somewhat about subsidiarity, as it were, in a clinical sense, people being treated before, being seen holistically for all their conditions in a way that might mean they don't end up in hospital. And as Anita says, I do think the integrated care systems, the idea they're going to work with sort of blended budgets or to a single control total, there will be much more incentive if they do work as intended, I think, for people to be seen in general practice and treated in general practice or in the community, and not only in hospital, or not end up in hospital.
Thanks, Sarah. That's a really good point. Let's go for another round of questions. Let's go for the gentleman at the front first, the woman on the left-hand side, and then the person in the middle.
Thank you. I'm Dr. Kaz Frisby. I'm a GP in London, clinical lead GP in London. I'm also a Conservative counsellor in Epping Forest, and I chair the CFOP NHS chapter. So we've talked a lot on the panel today about resilience. We've talked a lot about public health, and we've talked a lot about productivity and inefficiencies. So just to come in on a couple of points, I think, for me as a GP seeing patients every single day of the week, patient empowerment and public health go hand in hand. And I think we need to, as a government, we need to think about what we can do to help promote patient empowerment. I think that poses a really big challenge. We've seen in the media recently, there's been a significant uproar at lack of face-to-face appointments, or perceived lack of face-to-face appointments. So question to the panel on that front is, what can we do to help promote patient empowerment and get rid of some of the negative narrative, which has been very, very sadly, very, very dominant in the media? And on the point about resilience, we've again discussed at length about resilience within the population, but the recent survey carried out by the Royal College of General Practitioners showed that actually morale within primary care is at a record low. So, on the resilience front for GPs, I was reading an article not too long ago. 27% of all newly qualified GPs are thinking about moving on and moving abroad, or leaving general practice altogether. So what can we do to help promote resilience within the primary care workforce?
Great, thanks. Two good questions: how to empower patients and how to boost morale amongst GPs.
Thank you. Rachel, you made a really good point earlier, Paul, when you said about keeping people in their homes, taking care of them, providing them with dignity and care is incredibly important, and within the system that should be incentivised. As you'll probably be aware, unpaid carers, their family, their friends, provide a massive amount of care to people that, for whatever reason, are failing to be independent in that way. Does your incentivisation extend to those unpaid carers?
Great, thanks. A really interesting question about unpaid care.
My question is probably to Paul. We know that a lot of NHS doctors also see patients privately. So I was just thinking, what about disincentivizing NHS doctors, or forbidding them to see patients privately until the issue with waiting list is sorted? So at least temporarily, because I personally know people who tried to get appointments through their GP, NHS GP, and were unable to, but when they went private, they were able to get appointments.
Great, good question. Paul, I might put that to you first. Should we be forbidding doctors to do private work?
I'm not entirely sure that would be the right way forward. And let me just tell you why. It sounds counterintuitive. I think one of the ways that we're going to the only way we're going to deal with the elective backlog is effective use of the independent sector. And the independent sector did provide to capacity during COVID. They did. But this is going to require a monumental effort, and there has been a deal struck with the independent sector. But the NHS, a lot of the time, is not really a very good customer, and it's got to make sure that once having bought that independent sector capacity, that it needs to use it effectively. And as I said earlier in my remarks, I worry that there may, in isolated incidents, be a reluctance to use the independent sector capacity because of ideological reasons. I think a lot of surgeons who operate in the independent sector, as well as in our NHS, will ultimately be treating the same people. and I think they need to work hand in hand with one another rather than necessarily just turning around and saying you should only now operate in the NHS. Well, I mean, I think the vast majority of the backlog is not believe it or not, is not necessarily. I mean, there are going to be elements of serious sort of operations. I mean, all operations are serious. Please don't misquote me. But yeah, I think a lot of it is going to be hip and knees. It's going to be hernias. It's going to be cataracts, and these are important because they deliver quality of life issues. I would hope there would never be a situation where someone who requires quite an urgent cardiac procedure does not receive it because someone is privately paid for a hernia operation. I don't think that exists.
I think let's bring that exchange to an end there. Paul, if I could just put one more question to you about this question about empowering patients. What do you think about that? How could the government try to better empower people to make decisions about their own health?
Well, I think it's part of it. Again, it's what I kind of said in my remarks. I mean, I think there is an element of, we assume, for example, if you're old, that you can't use various different technologies. I think that's been proved to be completely wrong, actually, but believe it or not, through COVID, because we've had to keep in touch with people and talk to people around the country, and Zoom has been used, and a lot of older people have been perfectly capable and of using it. But it's I also think that a lot of it is also about upskilling our population with the use of various technologies. I think various remote monitorings and things like that are perfectly I think very worthy of investment, and making sure that our population are able to check their own health. I also think the self-care is also a significant issue. Once you take away something that people have been used to, it's very, very difficult then to tell them to go back. And I think a lot of the kind of issues we're facing at the moment with GP appointments is because people were very used to being able to go and see their GP whenever they needed to. Now, capacity has increased significantly. I do think there needs to be an effort for anyone who needs to see their GP face to face should be able to do so, and I think it's absolutely wrong that's not the case. But I also think it's the public should understand that just because you've got a runny nose, it's not an excuse to go and see your GP.
Great, thanks, Paul. And Anita, on this question about kind of workforce retention and workforce resilience, what might be done about that?
So I guess a couple of things for primary care. I think we do need to worry about the atmosphere around primary care at the moment, and how we can get, probably part of this is much clearer communication with people about what to expect and how the service can be run. So we have done, as people have said, sort of like 3 years of innovation in 3 months. Yeah, and in some places then, how to get through, how to access, how to use the service is very clear to people. But in other cases, perhaps not so. And there's a point of stabilising the model. But also, I think this matters both, so that people can use services well and get what they need, but also that actually the atmosphere around primary care at the moment risks becoming a vicious cycle then, where people who work in primary care just feel like they can't do a good job. That it's too stressful, and they leave, and then it becomes worse. Part of the answer in primary care is about, which is what is happening at the moment, is about moving from a model which is principally or predominantly GPs to a full team and workforce, and that is happening. But again, that needs to be carefully communicated so people's expectations are clear, that you're seeing a physio because the physio is the right person to you, not because the GP is being difficult. So that's a key part of it, but also links partly to the point about patient empowerment, because there are a range of cases where, for example, I mean, we know in this country, we've worried about it for years, that we don't use the skills of pharmacists as well as we could, and we don't use the high street pharmacy as much as we could. We know that things like So, for example, we funded a project which looked at where children had turned up particularly babies, actually, young children, turned up in A&E with fever. And it turned out that they actually really didn't need to be there. Primarily, this was about reassurance. Yeah. In the moment when their baby's got a raging temperature and they're really scared, they're not very receptive to anything. But once you've been there once and everything's calm and they've established that the baby's okay, that's a really good moment to teach the parents to say, if happens and this is the set of combinations, then this is what you do, yeah? And this is what you should be worried about. But actually, if it's this, then you can manage it in the following way. And you actually give people more confidence and more skills for the next time. And there are moments, aren't there, with these sort of interventions where we go from just the narrow interventions, you know, to broaden that out to support people so that they feel more skilled and confident, and finding those opportunities for that intervention. Chronic disease is the obvious one, where you put on all the programmes, and some of the expansion in the GP workforce is with this idea of things like social prescribers and others who can do more of that to help skill people up so that they feel more confident with their own health and often actually as much with their loved one's health.
Great, thanks Anita. I think the only question we haven't come to so far is just this question of unpaid care and the support the government offers to people to do unpaid care. Does anyone on the panel want to come in on that?
I'm very happy to. I think, sorry for not answering your question. You directed it to me. I absolutely agree with you. You know, that unpaid care, I mean, just think about the amount of social care costs that unpaid carers prevent, quite frankly, and and how much they save the taxpayer. So I think unpaid carers are in desperate need of A, recognition, and I think B, significant input into whatever this plan is that we're going to develop over the next the white paper we're going to develop, and we shall turn into the plan to deal with this in 3 years' time.
Great, thanks, Paul. I think we've got time for one very short last question. I'm going to come to Richard in the middle row. Tell you what, no, sure, that's fine. Yeah, let's go to this gentleman. Sorry, Richard. You can put a question another time.
Sure. Sorry to begin. So I'm a GP as well. My name is Tiva. I'm also have the pleasure, luxury of sitting on the local acute trust as a non-executive director. So I see both ends of the floor. I think we've gone around the sort of room in conversation about primary care and the flow into ED. I see this problem every day in that patients, I think there's a misunderstanding of how the new system works, and there's a lot of GP bashing because of it. And we're delivering 20% more activity than we've ever done before, and there's still GP bashing from all angles, which doesn't help the morale, doesn't help the workforce. I'm one of the representatives for the Royal College GPs in the first 5 years of qualifying. Every day I get a message in the group from the representatives of newly qualified GPs of someone resigning from general practice. That's every day. That's people representing general practice, not just people on the ground, because of this monumental task which I'm having to tackle. And we get patients rocking up to A&E because of this lack of understanding of how the system works. With things like cough, I did a clinic on Thursday, which was 33 patients all day. All were coughs and colds that was coming in. Where I've got patients who are knocking on my door because they can't get the operation that they need. They've been sat on for 12 months. They would have gotten in 2 months pre-pandemic. So that means I can't deal with the usual care I used to do to provide primary care. And that means I can't do the primary care prevention stuff like cardiovascular disease, which prevents conditions happening, and therefore there is no more public health anymore that we used to do ourselves in primary care. So this is the knock-on effects we're having. So I think the fundamentals here is morale and retention. I know we're trying to do lots, but it's still not happening. People are leaving. We've got less GPs today than we did 5 years ago. I don't know who you want to, however you massage the numbers, we've got less GPs today, and it's getting less and less every day.
Yeah, thank you. So I think to put that into a question for the panel on kind of primary care in particular, we talked a lot about longer term measures. What can we do in the short term to improve workforce retention, let's say over the next year? Anita, also start with you.
So I do think getting the current model stabilised in terms of people understanding the workflow and GPs almost like, and the government and NHS leaders all being on the same page about this is how primary care is going to operate, this is what you can expect, this is what your responsibility is to deliver, is quite an important stage to go through. We are making some progress with the wider staff into primary care, but we need to go further and faster on that as well, and we need to obviously focus on, we've got a wave of older GPs. You say, I'm 54. Got a lot of GPs in their 50s who are thinking of retiring very early, and I think really exploring what we could do to keep them will be very, very, very critical. But it's going to be a bumpy ride.
Thanks, Anita. Paul, can I come to you?
Yes. So I think the answer to the question is a little bit is what Anita really said about having holistic services in primary care, and ensuring that you see the right person for you, and whether that's a nurse, whether that's a GP, or whether that's a physio or something or other, that really needs to be developed. I also think you need to free up your time. Okay, so there's two things here. So 40%. I fully understand that a lot of your time spent on bureaucracy. A lot of it's probably spent on 40% of it. Someone's told me earlier today on fitness notes and requests for medical records and all this. The government need to help you free up your time to do that, but you also need to help yourself, and you also need to ensure that you are following up on nurse-led prescribing. That you're only doing the things you have to do rather than the stuff that you've always done. I use the example of prescribing the pill. We don't need GPs to be doing that. And I know that we're doing it much less than you used to, but we shouldn't be doing it at all, really, in my sort of view. And then finally, another challenge is a lot of the anger I get about people not being able to see their GP face to face in my constituency comes from the style of the triage service that GP practices are providing. There's a 30,000 person GP practice in my constituency. 80% of the people don't speak English as a first language. 50% of people don't speak English particularly well. They'll see anybody who kind of comes to see them, and they have them queuing up and they'll go to see them. But also they have managed to triage quite effectively a lot of people that don't need to come and see them. And to be fair, it's a younger population because it's a lot of people who have come from overseas. But they do that really, really effectively. But on the other hand, I get complaints from people where the triage service is totally ridiculous. They're not called back and said they were going to be. They're they're messed around. They don't feel like they've been particularly served well. And if we can challenge, I'm not saying that's typical. I'm just saying that does happen in places. And if we can solve that problem, I think you'll find a lot more satisfaction. Patient satisfaction with primary care services. So it's a challenge really about how GPs practices handle their triage service.
Great, thanks, Paul. And Sarah, are there any final comments you want to make on primary care?
I was just going to make a point about the structure of primary care that we have in this country is by and large a structure in which somebody wishing to become a GP partner has to invest in that practice, and I think and take on the sort of massive admin burden that comes with being a sort of co-employer almost. And I think that's created considerable problems in recruitment, particularly in poorer areas where people, don't feel comfortable investing in the sort of bricks and mortar of a surgery. So I think a move towards more recognition that in some areas particularly we need more salaried GPs. I mean, of course, we are getting more of that, but I think that could be one way of helping the recruitment, because no wonder these 50-something doctors are getting exhausted, after 30 years of not only practicing medicine, but being a sort of small business owner in effect. I mean, that's a very exhausting sort of duality. So.
Great, thanks, Sarah. And with that, I'm going to bring the discussion to a close. For those looking for more reading on public services, I'd self-interestedly recommend the IFG's annual performance tracker. Do check out the Health Foundation's Real Centre, which has got a wealth of fascinating analysis, data, evaluation. It's a geek stream. This is the final IFG event of the day. We've got a packed day tomorrow, starting with a discussion about the impact of technological change on public services. The exchange room on at 8. So for those up early, or for those who don't go to bed, please do join. It is an excellent panel. Thanks for attending. Thanks to those who asked questions. Thanks for a brilliant discussion.